Hi, my name is Amy Gentry, and this is my special population presentation. I chose nephrology social work and will be focusing on chronic kidney disease. Chronic kidney disease is in 5 stages. Stages 1 through 3 usually has no symptoms. Stage 4, mild. End-stage renal disease, stage 5, is actually kidney failure. In kidney failure, our kidneys are no longer able to remove the toxins from our blood, excess fluids. The kidneys aren't able to produce a hormone that regulates blood pressure, a hormone that regulates red blood cell generation, and is unable to regulate our pH levels. Two of the main causes of ESRD are diabetes and heart disease. And an interesting fact that I found was that diabetes and heart disease are significantly related to adverse childhood experiences, and this is due to the trauma process, which elevates inflammation levels. My target population is ESRD. I will be looking at patients who are 65 and older who are on dialysis. The treatment team for a patient on hemodialysis in ESRD is that they have to include an MSW, and this MSW is called a nephrology social worker. Symptoms of ESRD. The two main symptoms that people complain of are fatigue or problems with sleep and sexual dysfunction. And interestingly enough, more women complain of sexual dysfunction than men. I don't know, I couldn't find evidence on why that was so, but I was thinking maybe a woman's ability to be able to talk to a clinician better about it than a male is one thing. So other symptoms, and I'll just hit the main ones, are swelling in the face, the hands, the feet, the ankles, lots of pain. They say that patients with ESRD have a high pain tolerance, just like oncology patients. So to complain of pain with a high pain tolerance shows you how high that pain is. A weight loss, changes in your skin. There are rashes that happen, and I looked up the rashes, and it's something similar or looks like a bad case of chicken pox or measles. Other things are bone fractures because of osteoporosis. Treatments. We'll be focusing on hemodialysis. Peritoneal is a stay-at-home treatment where a cleaning solution is inserted into the lower abdomen, and it pulls out toxins and excess fluids, and that cleaning solution goes out of the body. Patients in my demographic, 65 and older with end-stage renal disease, do not usually qualify for a transplant, but I thought this was interesting because I wasn't aware that they just add an additional kidney, so you actually have 3 kidneys instead of removing one of the other kidneys. Hemodialysis is where a port is put into the arm, a fistula or a graft, and blood is pumped out of the body through a filtration device that pulls out the toxins and the fluids that your kidneys are no longer able to do, and then the blood is directed back into your body. The uniqueness of my population. My population has the highest pill burden than any other chronic disease. These patients can be on 25 different prescriptions, and so when you think about prescriptions and the different instructions. So some have to be taken with food, some 2 hours before you eat, some on an empty stomach, 3 times a day, every other day. It becomes quite a burden. Comorbidities, almost everybody presents with at least one other chronic illness. Usually that's diabetes or heart disease, but we also see blindness, amputees, and with a 65 or older population, there is dementia. Hemodialysis is performed 3 times a week, and the least amount of time that you spend on dialysis is 3 hours. The nephrologist determines that based on your fluid levels and the amount of toxins in your blood. Generally, it's 4 hours. If it takes an hour to get there, an hour to get home, you're talking about 6 hours, 3 times a week. It's a part-time job just to get your dialysis. Then you have cardiologist appointments, the nephrologist, urologist, so it becomes quite the burden. There is a surgical fistula inserted in the arm that stays there. Supportive care. This is known as supportive care because the patient is slowly being poisoned. Their job of the team is to increase quality of life as much as possible. Another uniqueness of this population is that Medicare will only pay for ESRD supportive care, or they will pay for hospice. They will not pay for both. 20% of patients decide to come off of hemodialysis and die a natural death without hemodialysis. The number one challenge for these clients, 33% across the board of ESRD patients have depression. 44% of patients on hemodialysis have that. They, thought to be a result of a loss of control. The amount of time that you have to spend, the invasive procedures. Depression is the most common psychological problem among these patients. Clients who are depressed have a lower quality of life. With depression, lower quality of life with ESRD, plus the lower quality of life of depression can cause higher mortality rates. Due to the depression, the clients aren't able to participate in the care and needs that they have. They have direct instructions on fluid levels, diet, exercise, rest, and when you have no motivation or concentration, you feel hopeless, then you can't be a participant in your care. These patients feel inadequate. They have increased irritability and anger, which you will see sometimes in the dialysis unit. And it is considered a trauma upon trauma. Like I said earlier, a lot of these clients have high ACEs, and ESRD is considered as a trauma. So it is a double whammy. NSW skills and resources for clients who have depression. Assessment is a very, very important tool that you need to be good at. A lot of the symptoms of ESRD do look like depression, and so to be able to see the process of depression versus the symptoms of ESRD. Building a great relationship is important. Most patients prefer the relationship they have with their NSW over the relationships they have with the nephrologist, the nurses, the med techs. Those other professions are focused on tasks and keeping the patient physically safe. We as social workers are trained in relationships, and so patients do prefer us, and so building that good relationship is very important. Psychoeducation for the patient is very important, so having the patients to go over instructions again and again and again, because like I said earlier, with a lack of concentration and feeling hopeless, you have to repeat a lot of the education over again. They have found that cognitive behavioral therapy is a very effective therapy for these clients. Conflict resolution with the irritability and the anger, and then educating the staff. Again, ESRD symptoms can look like depression, and being able to educate the staff about depression and saying, hey, I know this looks like symptoms, but it could also be depression. Having those skills is very important. Another challenge is fluid non-adherence. This will apply also to medicine, diet, exercise, and appointments, but the number one complaint of clients is thirst. 10 to 42% of clients are unable to follow their fluid restrictions due to extreme thirst. They have a power struggle, internal power struggle going on about wanting to follow the guidelines and live, but they're also in a process of dying. They feel disempowerment, and having to log fluids, everything that comes in and everything that comes out all day, every day, becomes quite the task as well. Resources for non-adherence, patient responsive to the NSW. Again, you get better results when the NSW approaches the client to talk about fluid restrictions than you do a nephrologist. A program that I found that's been very effective with clients, it started off as an intervention for non-adherence with fluids, but they expanded it to medications, appointments, diet, exercise. It's called the Social Work Intensive, and it's a 6 to 8 week program. It can be done in a classroom setting with group support, or it can be done chairside in the hemodialysis unit. But it focuses on empowering the client instead of shaming them. A lot of times that's what clients get from the nurses and the doctors. The fluid non-adherence is an extreme challenge for the treatment team, and it ends up taking more time in the dialysis unit. Patients have been scheduled for a certain amount of time based on their wet weight, and that's the wet, or based on their wet weight. So when they come in and they have more fluid in their system than what they are supposed to have, then it takes more time for hemodialysis. And so it affects all of the ones on the renal team as well as the other patients who are waiting for their hemodialysis treatments. This social work intensive empowers the client. It doesn't shame them. It's approached as an experiment. Hey, I got this program I'm going to do, and I don't know if there'll be anything that'll be helpful for you, but if you'd like to come along, it's going to be on this day. And so a lot of patients like the experiment aspect of it. It's non-critical, it's patient-centered, and it focuses on cognitive, behavioral, and motivational-based therapies. Again, it's the relationship that you have to have good skills with as well. Skills and traits that I possess that I think would help me as a social worker. I really love the trust-based relational intervention program that I attended at Texas Christian University. It's attachment-based, and so to have those skills of empowering and building connection. The trust-based relational intervention is targeted at children with high adverse childhood experiences. And as I said before, a lot of these clients do have that. I have an educator background. I love to teach. I love to sit beside someone and explain things to them. I do have a medical background, and I also really love how everything fits together, how all systems affect each other, and the dynamics of that. I have an adopted daughter, and we adopted her when she was at stage 3 kidney disease. We did not know that she had kidney disease. Now she's in end-stage renal disease, and just a month ago was put on the kidney transplant list. This is not anything that I would share with a client, but I do feel like it gives me the ability to use my empathy and my ability to hold safe space for a client. And I think they can pick up on you understanding what they're going through. And then lastly, I have a servant's heart. My posed question is, how can we as social workers advance the public knowledge of adverse childhood experiences and their relationship to chronic illnesses? Resources I have for you: Up to Date is a website that has a lot of psychoeducation pamphlets or handouts on it. So if you decide that you would like to go into this field, you can find information on any topic that a client might have. The educational booklet for social workers interested in the nephrology field, it'll give you more in-depth information about the disease and about social work. And then lastly, of course, the National Kidney Foundation. These are my references, and I want to wish everyone the best this last week of classes and the rest of your academic career. Have a great evening.